Hey everyone, my name is Paul Foster. Thank you very much for having me to present. I'm an orthopaedic clinical teaching fellow at Musgrove Park Hospital in Taunton. I'll be presenting the mortality outcome following surgical decompression and stabilisation for MSCC patients in our spinal surgical unit. So MSCC is an oncological emergency, and surgical intervention may often be required to prevent permanent neurological compromise. However, in some patients, it may not be appropriate or in their best interest to intervene surgically. The decision to operate is closely tied to forecasted prognosis of the patient, and a common rule of thumb is that a prognosis of over 6 months is a relative indication for surgical intervention. In 1989, the Tokuhashi score was developed as a prognostic guiding tool for MSCC patients, and as you can see on the right, it takes a number of elements into account, such as the primary malignancy, the number and location of metastases, and the general condition of the patient, as well as the degree of neurological impairment produced. And the score given places the patient into one of 3 prognostic categories, whereby the higher the score, the longer the expected survival of the patient. Our department uses Tokuhashi scoring, among many other considerations, when planning operative intervention for MSCC patients. So in terms of methods, our DGH provides a tertiary spinal surgery management for extradural MSCC management. And surgery is carried out by one of 5 surgeons. The data was collected from the monthly spinal oncology MDT, which records all patients referred in with MSCC. And the data in this presentation refers specifically to patients undergoing emergency decompression plus or minus fusion. The factors we assessed included primary tumour, location and number of metastatic deposits, the Tokuhashi scores, whether the patient had surgery or not, time from referral to surgery, and the mortality and time from referral or surgery to death. Exclusion criteria were those patients with unknown primaries, patients who were found to have benign lesions, patients who underwent other forms of surgery such as kyphoplasty, and patients in whom it was impossible to retrospectively calculate a Tokuhashi score and had not had one done at the time. So you can see from the graph on the right that over a 4-year period, we had 171 patients referred into the service who met our criteria. The most common primaries were prostate, followed by myeloma, breast and lung. And of the referred patients, 69, so 40%, underwent surgery. And the mean time from referral to surgery was 15.02 days, with a range of between 1 and 133 days. But this included a number of early referrals who subsequently developed compressive symptoms. And so excluding those patients actually brings the mean time from referral to surgery down quite significantly. In terms of our results, so the mortality rate of operatively managed patients was 30.4%, 21 patients at the time of writing, and that's all-cause mortality taken from the time of surgery up until nearly the present day. The mean survival after surgery of these patients was 423 days, so quite significantly over a year, with a range of between 3 and 2,432 days. And looking into this data in a bit more detail, we found that lung with an average of 174 days and renal with an average of 66 days survived significantly shorter time periods than other primaries. And this graph shows the blue line showing the average post-op survival versus the Tokuhashi score, with the red bars showing the number of cases within each Tokuhashi score. And we found that patients who died after operative management had an average Tokuhashi score of 9.9. For non-operative managed patients, the average Tokuhashi score for those who died was 6. So our conclusions. So the oncological management of MSCC now offers several treatment modalities for different tumours. And the use of Tokuhashi scores to guide management have actually been controversial in recent years due to the many advances in oncological management available. And our unit data provides a validation of use of Tokuhashi score as one guide of management, among many others, with a mean survival after emergency surgery of over a year. Particular caution we felt should be applied to lung and renal primaries, which had a quite significantly reduced survival rate in our centre's data. So thank you very much, and I'm happy to take any questions at this point.